Hey guys, my name is Drew Charles. I'm an internal medicine resident, PGY2 at the University of South Florida, and today we're going to be talking about alcohol withdrawal. And the reason that this is important that we talk about alcohol withdrawal is because you can actually die from alcohol withdrawal. You can have a fatal arrhythmia. So today, our objectives, we're going to be able to identify what is alcohol withdrawal. I want you to be able to identify when a patient is going into alcohol withdrawal. We're going to go over when is appropriate to seek out help for escalation of care with the patient going into alcohol withdrawal. And lastly, we're going to go over how to treat alcohol withdrawal. So before we get started, I would just like to talk a little bit about the pathophysiology. So what is alcohol withdrawal? So chronic alcohol use will actually enhance your GABAergic activity, inhibit your NMDA receptors, and increase the amount of glutamate. So why this is important, because actually is when you remove the alcohol, you now have decreased GABA receptors. You have NMDA receptors that are now open for the glutamate to bind to, overactivates your nervous system, giving you kind of what is alcohol withdrawal. So the autonomic hyperactivity, where you see like the diaphoresis, the tachycardia, the high blood pressure, neuronal excitation, will be the alcohol withdrawal. Seizures, and then delirium tremors, which is kind of a combination of the two, along with altered mental status, confusion. And the reason that all this is important, because at the end, when we go over the treatment, this plays a role. So common causes that you'll receive overnight include the patient is acutely agitated. There's a change from baseline. They may have increasing seawall scores. I typically like to gauge around 15 to 17. When you get up to those numbers, I typically start to get worried. The patient may have had a seizure. And then altered mental status. The patient is confused, he's confabulating, he doesn't know where he is. These are the most common calls that you'll receive overnight when you need to be thinking about alcohol withdrawal. So when you get the call, the questions that you want to ask the nurse are their vitals. How's their heart rate doing? Their blood pressure? Are they satting okay? Are they on supplemental oxygen? Another question I want to ask is the patient hallucinating? Are they having visual hallucinations, tactile hallucinations? And then are they receiving any treatment at that time? Are they on fluids? Are they getting like multivitamin, thiamine, folate? The reason it's important to kind of get these baseline questions is you'll get an idea if you need to go ahead and give someone a heads up, like the MICU senior at night or one of your senior residents, to let them know, like, hey, I think this person's kind of going towards alcohol withdrawal. I wanted to give you a heads up. I'm going to go see the patient. So that leads us to the last thing. The most important thing from the slide is once you acquire all this information, go see the patient. Now that you've gone and seen the patient, you arrive at the bedside. It's important to do a thorough evaluation. The first thing you kind of want to do is just look at the patient. What are they doing? Do they look anxious? Are they diaphoretic? Do they look confused? Do they seem like they're with it? And then you want to ask them, if they're with it, ask them when their last drink was, because that's important to kind of gauge where you are within the alcohol withdrawal timeline, which we'll talk about shortly. Another question you want to ask them is, they ever had alcohol withdrawal before? The greatest risk factor for going into alcohol withdrawal is actually a history of alcohol withdrawal. Another question you want to ask them is, how much alcohol did they consume on a daily basis before they came in? And the reason this is important is because if you're only drinking a few beers a day, you're less likely worried about someone going into alcohol withdrawal, as opposed to someone who is drinking, 12, 15 beers a day or multiple liquor drinks at night. You would have to be more worried about the going into alcohol withdrawal. Other things you want to ask them, are they hallucinating? Do they feel like someone's in the room? Are they seeing things? Do they feel things on their body that aren't there? And then going back to their appearance, do they appear tremulous? And you can also bring both their hands out and see if they are having active tremors. So the withdrawal timeline I mentioned earlier is kind of going to give you an idea where you are within the alcohol withdrawal. And the important question, or the answer to the last drink question, will start you off right here. So you gauge when their last drink was, and if you're within the first 6 hours of when their last drink was, you have to worry about an uncomplicated withdrawal. So you're going to have, they may appear anxious, they may have some nausea, some vomiting, complain of some belly pain, a headache, and then the autonomic dysfunction, like we talked about in the prior slide, they may just have very mild symptoms, such as a elevated heart rate around the 100s, a mild blood pressure elevation. And then as time progresses, if you're within the 12-hour window, you have to start worrying about the hallucinosis. So when you're having hallucinations, whether they be auditory, visual, or tactile, and they may just appear paranoid. And of these, visual hallucinations are actually the most common in alcohol withdrawal. As you've reached the 24-hour mark, this is when you have to worry about alcohol withdrawal seizures. These are typically tonic-clonic seizures, so you get the whole body jerky movements, and they occur in phases, so multiple at a time. So they'll have back-to-back seizures. And then as you approach the 48-hour window, this is when things get very severe, and you're in the alcohol withdrawal delirium, also known as delirium tremors. This is when the patient will appear confused. They may be in and out of consciousness. They'll have the severe autonomic dysfunction, the tachycardia, heart rate up to the 140, severely hypertensive, not protecting their airway. This is when you should have already called for help when you identify this. And this is very severe because this is when you can actually die from alcohol withdrawal. You can have a fatal arrhythmia occur during this phase as well. All right, so once you've gone bedside and evaluated the patient and you determine that the patient is experiencing alcohol withdrawal, you want to start initiating the treatment for alcohol withdrawal. And the treatment involves administering benzodiazepines. And these are the three most common that we use, and each one kind of has a different clinical indication. Lorazepam, this one you can give if they have underlying liver dysfunction. So if they have underlying cirrhosis, it's okay to give lorazepam. The other one, chloridized epoxide, this one you cannot give if there is any underlying liver dysfunction or cirrhosis, because this one is actually metabolized by the liver. And the last one, diazepam, this one people tend to favor because it has a very long half-life, so it lasts a very long time. You don't have to give it as frequent as these. So once you've chosen the benzodiazepine that you're going to use on your patient, this is kind of the stepwise approach that I use when I approach a patient with alcohol withdrawal. So if they're not already on a seawall protocol, I go ahead and initiate that. And what that is a scheduled monitoring that is done by the nurses. And what they do is they assess the patient by a type of parameters, and they determine how much benzodiazepine they will give by how high they score on the seawall scale. And this is a PRN basis. If the patient is still having very high seawall scores, difficult to control, then what you can do is you consider starting a benzodiazepine taper. And at this point, I want to make sure that the patient is on IV fluids, multivitamin, thiamine, folate. You could consider getting an EKG to make sure that there's no underlying predisposition to any arrhythmias. You want to be able to get a baseline QTC. Go ahead and get the some electrolytes, because with the autonomic dysfunction, you'll have a lot of electrolyte derangements. And go ahead and get a UDS to make sure that there's no confounding toxins that you could be contributing to as well, or if they're withdrawing from other substances. If you've initiated both of these and the patient is still having very high seawall scores, very tachycardic, they look like they're impending going into the worsening of the alcohol withdrawal, like delirium tremors, you may want to go ahead and initiate a benzodiazepine drip. And if you're at this point in the stepwise approach, you want to go ahead and transfer the patient to the MICU. The drip can be monitored in the MICU by the MICU nurses, and they can have closer monitoring. The next thing is if the patient actually starts to have alcohol withdrawal seizures, you can give Ativan pushes. About every 5 minutes, you can give a push until they break their seizures. And then if the patient becomes acutely agitated, you can start, you have two different things that you can start. You can start dexamethasone, better known as Prexadex, or haloperidol. If you're going to go with the haloperidol pushes, you want to make sure that baseline EKG you got, that their QTC is okay. And also, if they're acutely agitated, you're having to use medications to help calm them down. You may want to consider making the patient NPO. That way they don't aspirate. You also may need to get a 1-to-1 center to make sure that they're not going to harm themselves. And last case scenario, if they are a harm to themselves or the nursing staff, you would consider restraints. But I typically try to avoid restraints, but sometimes you don't really have a choice. So in summary, this is how my stepwise approach to alcohol withdrawal, and we talked about the treatments. So hopefully by the end of this that you feel more comfortable. You're able to tell someone what is alcohol withdrawal exactly. You're able to identify alcohol withdrawal. You know when it's time to seek out help and reach out to your seniors to help you and maybe transfer this patient to the MICU. And you also know how to treat alcohol withdrawal.